Hi, my name's Dr. Matt Goebel. I'm a resident at Bay State Medical Center, and we're going to be talking about how to get better quality EKGs in the ED. So there's really two parts to getting high quality EKGs in the ED. The first is skin prep, and the second is putting the electrodes in the right place. So let's talk about skin prep first. Get it the first time. You do this by making sure that every patient gets appropriate skin prep. Every single patient should at least be wiped pretty aggressively with a washcloth to get any oils or dirt or whatever else off their skin so the electrodes can stick properly. Some men may need to be shaved. Men that kind of have longer chest hair, sometimes as the tech, you can kind of run your finger between the hairs and like part it to put the electrode down. But people that tend to have the shorter, curlier chest hair, sometimes they really just need to be shaved so you can get the EKG properly. Now, if they're just super diaphoretic and nothing is going to stick to them, you need to go to Plan B, which is using an actual skin prep product, either Sure Prep or something like Cavalon wipes. They put a film on the skin so that both protects the skin from the adhesive of the electrode and helps the electrode to stick to the skin. You should only need these in the super diaphoretic patients. There are also other EKG stickers besides the ones you normally use that are better for people that are just super sweaty. So that's about all there is to say about getting them to stick to someone, but really the most important part is making sure that your electrodes are put in the right place. Now, if you put the limb leads on the chest, or if any of the chest leads, called the precordial leads, are off by more than 2 centimeters, which is less than an inch, you can mask or create ST segment changes that it's going to change how the doctor interprets the EKG. So here's a case from the ED from just the other day. You can see here that this EKG looks abnormal, mostly in leads V1 through V3, where it looks like there's a right bundle branch block and some ST elevation. And this was the EKG done later with the leads in a different place. So here's comparing the two. The electrodes on the left are in the wrong position. They're actually too high. And the electrodes on the right are in the correct position. So you can see how it looks really different, and it could really change what ends up happening with this patient if the electrodes are in the wrong place and the doctor isn't getting good information. So let's talk about where to put the leads. The limb leads need to go on the limbs, not on the torso itself. So how close can you get? Because we're always trying to kind of split the difference between getting closer to the chest so there's less artifact and being on the limbs so that we get a correct picture. Well, for the arms, the cutoff is where the deltoid inserts onto the humerus. So anywhere from here out you can put it. And then on the lower extremities, your cutoff is the inguinal ligament or the inguinal crease. You can go anywhere past that. So depending on the patient and what kind of clothes they're wearing, how easy it is to access their limbs, you may put them close, or you may opt for putting them down on the ankles, where it would be easier to just pull their pants up, pull their socks down, and attach them there. So that's the limb leads, but let's talk about the precordial leads. So on the precordial leads, there's landmarks you need to palpate on every patient to make sure that you're getting them in the right spot. And the most important landmark is the angle of Louis, also called the sternomanubrial angle, also called the sternal angle. And this is where the manubrium joins the sternum right here. On some older patients, you can see that it's like very prominent, it kind of pokes out. This is where the second rib joins the sternum. Now, if you can't feel that exact angle, you can estimate it by measuring 3 of the patient's fingers down from the jugular notch. The jugular notch is this notch right here, and then 3 fingers down from that should be that bump where the second rib is joining the sternum. And so when you palpate that bump, and then you come off to the side and fall into a space between 2 ribs, you're in the second inner space. The other lines that are going to be important are the midclavicular line and then the axillary lines. So the thing that's tricky about the midclavicular line is that the clavicle extends from here all the way out to the end of the shoulder. So the midclavicular line is actually right about here. Often we're kind of underestimating the length of the clavicle because we forget that it runs this whole distance. Now the axillary lines, there's 3. the antero, middle, and posterior axillary lines, which is just the front, middle, and back of the armpit, basically. So let's talk about where the precordial leads actually go. So V1 is going to go in the fourth intercostal space on the right sternal border. So you're going to start at the angle of Louis. You're going to feel your finger sink into the chest there, and that's the second. You're going to feel down one more rib space. That's the third. You're going to feel down one more rib space. Now you're in the fourth. Right at the edge of the sternum will be where V1 goes. On the opposite side, you're going to put V2. Then what I want you to do is you're actually going to skip over to V4. So you're going to fall into the fifth interspace and go over to the midclavicular line and put V4 there. Next, you're going to put in V3 because V3's definition is it is halfway between V2 and V4. Next, you're going to skip over to V6. V6 is in the mid-axillary line, the fifth intercostal space. So although this picture shows them kind of swooping up and following the rib space, what I actually want you to do is just go in a straight horizontal line over to the middle of the armpit. So you're going to start at the sternum and go over at a 90-degree angle, follow directly across the chest, so that 4, 5, and 6 will end up being in a exact straight line. It's perpendicular to the sternum. So 6 is going to go in the mid-axillary line, and then 5 will either go halfway between 4 and 6 or in the anteroaxillary line. Technically, it's supposed to be anteroaxillary line, but if you're having trouble finding that exact spot, you can put it halfway between 4 and 6. So let's talk briefly about posterior leads. When we are worried that the patient may be having a posterior MI, and so we decide to do posterior leads. So you're going to follow 4, 5, 6, that line you made, you're going to follow it around the back to put 7, 8, 9. And 7, 8, 9, 7 is at the posterior axillary line, which is just the back of the armpit. 8 is in the middle of the scapula, and then 9 is just right to the side of the spine, and those are going to be in a straight line. So 4, 5, 6, 7, 8, 9 should be in the exact same horizontal plane coming around that's perpendicular to the spine and the sternum. If you're asked to do a right-sided EKG, you're just doing the mirror image of everything on the right side. Sometimes a doctor may only ask you to do V4R, and that's because V4R is the most important of these for seeing a right-sided MI. The rest are kind of just adding additional information. So let's talk about what to do with breasts. This is from a case report in the British Medical Journal where they talked about a patient who had a known pathologic EKG. Their EKG appeared normal depending on where the electrodes were placed, and this was whether they were done on the breast or under the breast. On the breast, where you're actually palpating the landmarks, is actually the correct place to go. The problem with putting the electrodes under the breast is you're lifting the breast to put the electrodes, and then you let go, and then the electrodes will slide down and out of place. And you can see that demonstrated in this graphic that they have here, where the V4, where it labels as wrong position, is under the breast. Probably when they lifted it up, it was in the right position, and then as soon as you let the breast tissue down, it falls out of position. So it's better to just put the stickers on in the right place where the breast lies, so you know that it's going to stay there. I also really like this quote from the article: "Breast tissues are fake friends and definitively not a good point of reference." What they're talking about is for electrode placement for an EKG. So not only is this the medically or technically correct place to put them, but our patients actually prefer it. In this study, they were having paramedics do 12 leads on patients to see what their preference was in terms of lead placement. And they found that more women preferred electrode placement on the breast tissue rather than beneath the breast because it required less manipulation and felt less intrusive to the participants. So, one last tip. When you're using our EKG machines, there's this little remote, and there's these buttons on here which you may have never used. But once you have the patient all hooked up, you don't have to go back over to the machine to start the EKG or the rhythm strip. You can press this button to do a 12 lead, you can press this button to start a rhythm strip, and you can just press this button to stop the printer. So it is completely possible to get good EKGs with the tips that I've given you on almost any patient. I mean, this is not a great quality EKG, but it's certainly readable. What I want you to note here is that this patient was actually walking on a treadmill at 2.5 miles an hour up a 12% incline when this EKG was done. So if we can do that when someone's walking on a treadmill, you can get it on absolutely anyone that's lying down in the ED. So I hope you found those tips useful and that you'll be able to use them on your next shift. Thanks.